I like to invite Dr. Ishrat Jahan Shimu for her presentation regarding tricuspid valve endocarditis. It's time to pay back to the forgotten chamber. Dr. Ishrat Jahan Shimu, please.
Assalamu alaikum and very good morning to all. Honorable chairpersons and panel of experts and learned audience, I am Dr. Ishrat Jahan Shimu, Assistant Professor Cardiology in ICVD, presenting my case. This is a case-based presentation and my case is tricuspid valve endocarditis. It's time to pay back to the forgotten chamber. My case is middle-aged female who got admitted with fever and shortness of breath for 3.5 months. And on examination, she was moderately anemic with a systolic murmur in the tricuspid area. She had no previous history of structural heart disease, and she was not an IV drug abuser. And her investigation shows neutrophilic leukocytosis, blood culture was negative, and serum creatinine was slightly raised, 3.5 milligram per deciliter, and ECG was normal, and ultrasonogram was also normal. And this is her echo. On parasternal long axis view, it shows normal looking left atrium and left ventricle, but right ventricle seems to be enlarged. And this is normal, LV systolic function was normal with 61% EF. And this is parasternal short axis view, which shows there is a large vegetation attached to the anterior tricuspid leaflets and septal tricuspid leaflets and moves with it. And this is right one is the apical 5 chambers view, which also shows there is a large vegetation attached to the both anterior and septal leaflets of the tricuspid valve. And this is the zoom view, which shows the very irregular large vegetation attached. And this is RV inflow view, which shows that septal leaflets is also there is a vegetation attached to the septal leaflets of the tricuspid valve. And this is 4-chamber view, which shows tricuspid regurgitation. And there is severe tricuspid regurgitation present. And this is the tricuspid valve parameters, which shows the gradient is normal, but there is severe tricuspid regurgitation. And this is the vegetation size, which is large normal. Other valves gradient was normal. So my final echo reports was suspected tricuspid valve endocarditis with flail tricuspid valve leaflet, severe tricuspid regurgitation with PSP 36 millimeter of mercury, and interatrial septal aneurysm was present and dilated right heart with good both biventricular function. Patient before got admitted in our institute, she received injectable antibiotics, vancomycins, and we stopped all types of antibiotics and sent for the blood culture again. 2 sets of blood cultures were sent and all were negative. So we decided to the fungal culture, that was also negative. We screening for the TB, including quantiferon TB gold test, which was also negative. So we started what we should do, and we started for atypical coverage of organisms and started with the rifampicin and ciprofloxacin. And as patient was anemic, we transfused 2 units of blood for her. But still patient was symptomatic, her symptom was not improved at all. And so what should we do? So we should thinking of surgery and consult with the surgical team. And the recommendations for surgery was when microorganisms was difficult to eradicate, or persistent tricuspid valve vegetations more than 20 millimeter after recurrent pulmonary emboli, or right heart failure due to severe tricuspid regurgitation with poor response to diuretic therapy. We discussed with the cardiac team, and they also discussed about the risk of the cardiac surgery, and also discussed with the patient party, and at last they agreed to do the surgery, and surgery was done. And excision of anterior and posterior leaflets of the tricuspid valve vegetation was done. Tricuspid valve was replaced by the tricuspid tissue valve, St. Jude's 29 millimeter, and repair of the interatrial septal aneurysm was done. And histopathology shows fibrocollagenous tissue showing degenerative changes, thrombus, infiltration of the inflammatory cells. And also there was culture sensitivity test was done, which was negative. And this was the post-operative echo, and it shows normal functioning LA and LV. And this is the normal functioning prosthetic tissue valves in the tricuspid valve area. The tricuspid regurgitation, no tricuspid regurgitation, And these are the zoomed view of the prosthetic valve, normal functioning valves, and the tricuspid valve gradients across prosthetic valve gradients across the tricuspid valve. It's normal, and no paravalvular leakage or anything else. Patient was feeling good. And this is the post-operative final reports. That is, there is normal functioning by a prosthetic valve with good biventricular function. And patient was clinically good and follow up to us. But we are still in dilemma. What was the cause for this tricuspid valve endocarditis? We have no organism. We couldn't find any organism, or there is no predisposing heart disease. So my takeaway message is infectious endocarditis is uncommon in patients who are not drug abusers and have no predisposing heart disease. But it is tricuspid valve involvement in a patient with no predisposing condition, a structurally normal heart, is a clinical rarity in which the diagnosis can be quite complicated. So my heartiest gratitude and acknowledgement to my unit chief and mentor, Dr. Mohammad Jilur Rahman sir, Associate Professor, Department of Cardiology, NICVT, Dhaka, Dr. A.K. Monroe Islam, Associate Professor, Department of Cardiology, NICVT, Dhaka, and the heartiest gratitude to Dr. Sanjay Raha, Associate Professor, Department of Cardiac Surgery, and his team for this wonderful surgery. And that's all for my presentation. Thank you all for your patience hearing.
Thank you, Dr. Shimu, for your beautiful presentation, and thanks again for finishing your presentation in time. And now I like to request Dr. Zulfikar Ali Lelin sir to say something about tricuspid valve endocarditis, culture-negative endocarditis, and when we should refer our patient to surgery in case of endocarditis. Zulfikar Ali Lelin sir, please.
Already Shimu has said all the things. I think tricuspid valve endocarditis is not common. It is less common. I think this is all from me.
I want to ask you one query. The morphology movement of the lesion that you have seen, although the views were not the classical, why not it is myxoma? It's a large, highly mobile attached with the tricuspid valve. Why not it is myxoma?
Sir, a patient had a fever for persistent for 3.5 months, and the structure attached to it is moving with the leaflets only. There is no other sites involvement, only the valve is involved. So
your answer could be better that two separate cusps are involved, and also the histology had proven and excluded the diagnosis of myxoma.
I want to give one message to my junior doctors or my students. That is, there are 3 leaflets of the tricuspid valve, but posterior leaflet is only seen in RP inflow view. It is not the septal leaflet. And you can see the septal and anterior leaflet in tricuspid for some.
I have shown the RP inflow view for septal.
RP inflow view, RP inflow view shows the posterior leaflet. Yes, that was the posterior leaflet, not the septal.
Yes, sir.
Yes. Okay.
Yes, sir has picked up the right thing, and you mentioned septal leaflet in place of posterior leaflet.
Sorry, sir, this was my. It was the posterior leaflet. For this, I have shown this slide.
Thank you, Dr. Shimu.